Imagine a healthy 28-year-old woman. She exercises, eats well, and has zero obvious risk factors for cardiovascular disease. But without warning, she suffers a medical emergency. A massive blood clot has rapidly formed in the deep vein of her leg, cutting off circulation. A spontaneous blockage like this in a healthy young adult is a statistical anomaly. It's an immediate signal to the medical team that something is malfunctioning deep within her biology. To find the cause, the doctors order a standard coagulation panel. This test measures exactly how many seconds it takes for the patient's blood to form a solid clot. The results are baffling. The lab report indicates that her blood is taking an abnormally long time to clot. This is the central contradiction. Physical reality shows a patient with life-threatening blockages, yet the chemical data insists her blood is refusing to clot. To resolve the mystery, we have to look past the macro symptoms and dive into the microscopic environment of the bloodstream. The culprit is a rogue element of her own immune system, antiphospholipid antibodies. In this case, these antibodies are aggressively latching onto beta-2 glycoprotein 1 proteins located along the inner lining of her blood vessels. This binding triggers a destructive chain reaction. It activates platelets and the complement system, essentially tricking the body into an emergency repair mode. This cellular storm is what is actively building the blockage in her leg. Inside the living body, these autoimmune antibodies act as powerful procoagulants, driving a deadly clotting cascade. So why did the lab test suggest the exact opposite? To see the deception, we have to follow a blood sample into a test tube. In a standard clotting test, technicians add artificial phospholipid molecules to the blood. This provides the chemical fuel necessary to trigger a rapid clotting reaction. In the patient sample, the antibodies bind to these artificial reagents rather than the patient's cells. By consuming these phospholipids, the antibodies starve the chemical reaction of the fuel it needs to proceed. The test artificially stalls, incorrectly suggesting a risk of bleeding. This is the lupus anticoagulant paradox. The antibody's behavior in a test tube is a chemical artifact, masking the hypercoagulable threat inside the living vessel. Recognizing this paradox allows physicians to move past the confusing lab data and officially diagnose the patient with Antiphospholipid Syndrome, or APS. This antibody's profile confirms the systemic stakes. Without management, the patient remains at high risk for recurrent arterial thrombosis, miscarriage, and preeclampsia. To prevent future clots, the patient must immediately begin lifelong systemic anticoagulation, typically using the medication warfarin. Warfarin suppresses the clotting cascade, artificially balancing the scales to counter the rogue antibodies. This gauge shows the International Normalized Ratio, or INR. The clinical goal is to keep the patient's levels stabilized between 2.0 and 3.0. Identifying the underlying paradox of APS allows modern medicine to manage a once invisible threat. Maintaining this delicate chemical balance allows clinicians to prevent crises and ensure the patient's long-term survival.